Welcome to another episode of Digital Health Innovations for Long Life. Today we have with us Dr. Sundara Kumar. He is a pulmonologist and is also a medical informatician working at GKNM or GK Naidu Memorial Hospital in Coimbatore, also known as the hotspot for medicine and healthcare in South India. We will listen to him today on his life course, but also, as you all know, we focus on digital health, what made it interesting for him to get into digital health, his opinion on how digital health is going to progress, his experience, and also we'll listen to him on what can be taught to our students at the School of Digital Health here at Mallareddy Vishwavidyapith. Welcome to our podcast, Dr. Sundar, if I can call you that. Thanks for coming to our institution, and can we start the podcast?
Thank you, sir. Thank you. Let me first introduce myself. I am Sundara Kumar, practicing pulmonologist in Coimbatore. Bring me from my background, I am from a poor, agriculture family in a remote village in Cuddalore district. My father envisioned to put me into medicine. So I started my career as a doctor. Meanwhile, initially I've been into pulmonary medicine, then I was in emergency medicine for a while, developing emergency medicine in this country where it was not even available. It was called as a good old casualty. That was my initial change management challenge which I took over. Later on, I've been practicing pulmonologist parallelly, and as you all know, the hot word now, the digitalization, changing towards digital way of working, happening in every field in the world. It didn't leave the healthcare sector also. So we started thinking of implementing digital data entry process. I call it a digital data entry process. I'll tell you why I call it that way. Called electronic health record, electronic medical record. We wanted to change the way the doctors practice, move them from writing it on a paper to doing it on a digital platform called electronic medical record. I was assigned as a clinical champion to promote digital transformation and to convince my fellow colleagues called the doctors to fall in line and take it forward from there. That was my initial assignment given to me by my management in GKNM hospital. As I started doing implementation, I was just doing implementation, taking it forward among the clinical professionals and the paramedical professionals who were supporting the doctors. That's what we have been doing there. Later on, as I see the software, the so-called electronic medical record given to us by a third-party vendor from outside, I felt there is a lot of deficiencies in that particular software, and there is a big gap between how we clinicians work and how the software is being designed.
We'll hold that thought for a while, sir. So we'll just go back to a little bit of your past. Can you please tell us where did you study, and then your schooling, college, and post-graduation also?
Okay. I started my primary school from Dindivanam, from let's say LKG to 5th standard. Thanks to my father, who was third standard person who wants his son to be an educated person. From there I moved to Trichy to do my high schools. From there I came to Coimbatore and did my MBBS from PSC Institute of Medical Sciences in Coimbatore. Later on I went for my post-graduation in respiratory medicine from Chennai Medical College. Back to Coimbatore and been in the Department of Respiratory Medicine for a while. Then I moved to casualty, assigned the responsibility of changing casualty to emergency medicine.
Right. How difficult was that change, changing from casualty to emergency medicine?
No, change is not an easy task. Yeah. Always, change is always, even for the self or even for you want to change somebody else, it's even more difficult. So when I say change, so you have to convince the people who are working in the department first. What is emergency medicine? You have to make them understand what is emergency medicine. The way it's being practiced in the West is totally different from the way it's being practiced. I'm sure everybody would have been seen a place called Casualty in one of our government hospitals or even a private hospitals. There was few beds and with some few black and white monitors blinking here and there, and people will be waiting there and nobody to take care of them immediately. And there is nothing called triage or golden hour. All those concepts are not there. So I happen to create the process as a department in PhD Institute of Medical Sciences. In the process, I happen to be part of a group called Indo-US Emergency Medicine Group at a national level, where we started moving towards a complete changeover in the country. As part of that, see, there's nothing like you can't bring in changeover without teaching the next level of doctors. So we decided to bring in MD, emergency medicine, as a broad specialty. So we were pushing. That is the biggest challenge. Getting the top boss sitting in Delhi, agreeing that to bring in another specialty into as a broad specialty in medicine is a big task. But we were able to convince them, please them, cajole them, whatever we could do it. And we did it. And finally, MD, emergency medicine, has been announced in 2009 as a broad specialty in our country. Now, yes, emergency medicine is a different game altogether, where there is a standard of care for the needy population in the country.
I think that's a fantastic achievement, sir. Even though it is similar treatment for a similar condition, I think time makes a lot of difference, whether it is pediatric versus geriatric, whether it is normal care or otherwise emergency care. I think time makes a lot of difference, and you need to have a very specialized training for emergency medicine. Also, one more interesting statistics that I came across is, I'm not sure if it might actually apply to Coimbatore, but recently I was speaking to a person in Lucknow, and he said only 2% of patients being admitted in emergency medicine department in one of the largest hospitals, government hospitals, actually come in an ambulance. In fact, like, they come in just about every other vehicle, and I'm assuming things are far better in Coimbatore. So there are still a lot of challenges even with regard to access in emergency medicine, and once you reach, there's an utmost critical time, so you need to follow certain processes and you need to have a clear step-by-step process to kind of ensure that the patient is taken care of, perhaps stabilized, and a quick thought process to understand what needs to be done. So it's really a specialized care also. So from there, how did you kind of get back to pulmonology, sir?
No, I never left pulmonology.
Oh, okay.
I've been parallelly working on pulmonology and emergency medicine as well. I've been practicing pulmonology till now. Then I moved from PhD to GKN Hospital as a pulmonologist.
When did this happen? Can you put a year to this?
2010.
Okay.
I moved from PhD to GKN Hospital as a pulmonologist. Even in pulmonology, once upon a time, pulmonology is called as TB doctor.
That's true.
Now that's another challenge, to move from being called as a TB doctor to an interventional pulmonologist. That's a level of pulmonology care nowadays. So I happened to develop the department in such a way, getting people who are trained into interventional pulmonology, more knowledge people, youngsters to be part of my team, where we started developing it. The department of pulmonology is at a level now where we can do all interventional procedures, starting from basic COPD asthma treatment, allergy treatment, to interventional pulmonology, diagnostics, therapies, everything being done in our department. That's another thing which I could, but I felt that was never a challenge, because that's a field which is evolving, because it was existing before, so it was evolving. So I just need to support as it evolves. That's it.
And I think, like, as you rightly mentioned, previously it was all communicable diseases and TB was a primary communicable disease. Now it's become lifestyle diseases, where there's actually more allergies, there is actually more respiratory conditions, and of course we all know COVID, which actually is a severe respiratory distress condition. So I think respiratory diseases is evolving into many subspecialties or even super specialties, and pulmonology is becoming a continuous medicine also. How did you get interested in digital health or the informatics side, sir?
No, I wouldn't say I got interested into it. The management decided, as I said, the management decided to move towards digital way of working in the clinical entry, document entry, and all that stuff. So they have been talking to all the clinicians through a non-clinical person, and there was less complaint. The clinicians were not even yielding to the change process. There was why things I'm fine with writing it, why things are going good only, why do you want to change over and all this stuff. So management took an out-of-the-box thinking. They want to create what is called a clinical champion. So they want to bring in one of the clinicians into the informatics arena to take it forward among his own colleagues. So that was my management decision to bring me into informatics. I was initially a clinical champion. That's it. So to understand what is this digitalization process, how do we do digitally everything, and same way, I have to communicate and convey to my other clinicians how it works, how it doesn't work. Sometimes, you have to go with their way of saying that. Sometimes they'll be keep on cribbing, I also should crib along with them until they do. And all those things should, that was the initial thing. But the same way as in casualty to emergency medicine transformation, here also I saw there are a lot of deficiencies. I wouldn't say there is a deficiency. There is nothing like happening in this country, but we have started talking like that. See, for example, government, the National Health Authority started talking about digitalization process, ABDM and all this thing probably 5 years even before. Only the hospitals are trying to understand what is all this, and they are willing to get into digitalization process only recently, probably for another 2, 3 years or 4 years before. They started getting into the digital way of data entry. I repeat the same word again for the second time. Digital way of data entry. That is the thing. So when I saw that, this area needs a lot of change management process. One, the way the doctors perceive. Two, the way the industry perceives. Three, the way the government perceives. Four, the way the end stakeholder, the patient, perceives about all the digitalization process. So I started, attending conferences because there is no, learning domain was existent at that time when we started as a course or anything.
So when did you start this? Can you again put a year to this?
I started in 2020.
And as you rightly said, the government has been talking about it for longer, and several management now want to digitize healthcare services. Now, what do you think is the potential of digital health? There are a lot of practical challenges which we all know, but what do you think will be the potential of digital health maybe 5 years or 10 years down the line in a very imaginative way, sir?
See, when you compare the present non-structured way of data, handwritten paper on a paper, when you compare to that, when you think of the digital way of working, at least, I would say there is a near, I wouldn't say even now the perfect data is available. I wouldn't accept that the data are perfect, but at least there is a mechanism in place where the research scientists or the predictive scientists can pull out the data from the digital thing rather than the previous one called digitization, where they just do a PDF or just put scan copy into the case sheet and save it.
I wouldn't agree that as digitization at all. In fact, it complicates a lot of things.
Yeah. So that's what they've been doing. Now at least, when you start typing end-to-end, the CPOE, prescription, diagnostics, investigation reports, everything, and typing into a structured way of doing it, and it's easy for the person who wants to do an analytics and do a predictions and probably bring in a proper corrective action based on the data being implemented, typed into the EMR system, provided if the data is typed appropriately.
That's perfectly said, sir. In fact, digitization has to happen at the first step, not somewhere in the middle. In fact, If it happens somewhere in the middle, which is scanning all these copies or then entering summary data, it really does not make any kind of a change at all. In fact, in my opinion, it complicates things. But having said that, how difficult, I wouldn't even call it as easy, but how difficult is it for the practitioners, especially the healthcare staff, healthcare workers, doctors, nurses, how difficult it is for them to enter data at the primary level?
Okay. Yes, it is difficult, no doubt about it, but I wouldn't say it's impossible. It is difficult looking at the various things. One is the change management. First, we have been used to a comfort zone called handwritten prescription, handwritten case sheet, everything. And now you should see the handwritten case sheet how we write. When the patient comes for the first time also, there won't be a detailed history also will be there. You should see when there will be one small notebook sort of a thing, and there will be something written in the notebook. When they come for the next time, continue all. They don't even write anything, and they say continue all. Repeat all, continue all those things happens in the paper document in the See, but the other important thing, as we have been discussing, is the volume of the cases being seen by the healthcare worker at every level, primary, secondary, and tertiary care levels. But the bottom line is digital transformation. See, we can't simply say, based on the caseload, they won't be able to do all those things. Thing is, the administrators or what you call so-called policy makers should be in a position to understand the digitalization process end-to-end completely and provide support so that the process of digitalization happens properly. So you can't say simply it's not possible. Yes, it is possible, but the thing is it's a matter of time.
It's not impossible, but you need the right support and you also need the right resources to actually make it happen.
Yeah.
What are the other challenges that you actually see in digitization, sir? I mean, the availability of computing, the availability of skills, the availability of time itself, because as you mentioned, India is probably the most populated, not probably, it is actually the most populated country in the world. And any hospital, any successful hospital you actually go, the OP is not in tens or hundreds, it's actually in thousands. Every doctor sees again 100 patients a day is not very uncommon. In fact, it's very common to see 100 patients a day. And then even if you are doing procedures, again it goes into dozens rather than one or two every day. So the numbers itself are a challenge. And the second challenge that I would probably look into is the language itself. Because in one side you are talking to the patient in a local language, the second side you are actually entering data maybe in the local language or in English. So again there is a bilingual story that's actually going on. How much of this is a complication and how much of it is okay to actually go on and implement?
Okay. See, every changing especially from a comfort zone is not an easy task. Yes, it's a challenge. It's a big challenge. When I look at it, the challenges, one is always the change management is the biggest challenge. Top from the administration. See, though the government has been saying or talking about this change management process of digitalization, ABDM, they have created an infrastructure for interoperability, all those things. Even though the front end is still not ready, but they have created infrastructure for interoperability and all the stuff.
Absolutely.
Right. So, changing the mindset is the biggest. Changing the mindset of the people is the biggest challenge. So, resources, yes, we can buy it, we can invest, but even when I say we can buy it, it's not that easy for everybody. So, let's say for a government setup and a private setup, there are two ways of working in Indian health sector, private and a public sector. In a private sector, there is always an investment plan, there is always an ROI sort of a thinking, but whereas in a public setup, there is an investment plan, yes, and we all know what are the pilferages happen to the investment plan, and nobody worries about the ROI in the public sector. So naturally, it is difficult to push it in the public sector In a private sector, yes, because it adds value to their way of working. It creates a better feel for their own clients. Now this thing can happen appropriately. But in the public sector, things are different. Two. Three, as you said correctly, India is a multilinguistic country and India is a country of diversity. And how do we document in the sheet? See, for example, and every state has its own, ifs and but, because healthcare is a state subject in India. You can't say it's, for the whole nation there is one rule. Every state. For example, in Tamil Nadu, we always write to say paracetamol. You have to write that in Tamil as paracetamol. It's all, geopolitical, and it's all about political, indifferences among the, parties, and they bring in changes, all those things. So those are the other things. Though we say we have voice to text, which can capture any language from the Indian context, though we have, I came across a few voice to text tools to make things easier, as you said, to address the, let's say, 1,000 patient to be seen. If you have a voice to text, as I keep talking to the patient, it keeps recording the thing. See, there is a problem again, how many languages we are going to bring in. Though there is one language tool that's already implemented in the parliament, which converts everything to their regional language of choice, so they can understand better. Maybe. So we tested one thing, we tried to speak in Tamil.
I'm sure that's not medical grade.
No, that's not a medical grade.
That's a local language. I mean, even if you listen to YouTube videos, you can actually choose languages and then it will give you a subtext in translation, but we all know that how much of errors are there. So I think medical grade is different from normal grade, normal language grade.
Yeah, exactly. So when we tested speaking in Tamil, Malayalam and English, the output looks also, looks very great in English.
Yes.
But does it really transcribe what we really spoke? That's a question again. So these are the major hurdles. One is people need to understand why this changes. They have to come out of the comfort zone. They have to change. Second thing is policymakers will understand where all we need to address all these issues.
You mentioned about documentation, and you also mentioned that in government services things are different. Private services, they look at ROI. There's a little bit more push. Who tells these vendors what to do, and how does this implementation actually happen? Can you kind of take us through step by step if possible?
Okay.
Sir?
So again, when you look at the software is concerned, there are people who develop their own software within the hospital, in-house software. There are people who just get the vendor to, they just plug in the software given by the vendor and all those issues. To my knowledge, there is no standardized way of teaching the software developers what to be developed in the software. See, out of my experience with the software which we have been trying to use it is, when we got it, there was just a 6 tiles saying that complaint, history of present illness, past illness, prescription, diagnosis. That was the thing we were available initially. I was talking about the tile. When you go inside, there are a lot of other issues inside the thing. Okay, and there is no uniform way of doing it. So, but when you ask a software vendor, and they always put it the other side, there is no uniform way of practicing in India. See, even for a pulmonologist, in my own team, 4 of us, there is a subjective variation of treating the same disease by the different doctors. So, there is nothing like, when you look at the software product, they always talk about care pathway, they always talk about CDS and all those things, all jargons, and it looks very, sugary. When you say, CDS and care pathway, it's all very sugary and looks also they are great. But in the Indian context, see, for example, I tell you, in one of the care pathway, they say we have to do throat care, one test. Now that test is going to cost 2,500 rupees for the patient. What's the point? My patient may not be in a position to afford it.
Yes.
So that's not the thing. So when the software is given to us, we went through it, and started customizing to our needs. That's what has happened. There is no standardized way of training or standardized way of telling the technical person what the clinician wants. That's exactly what's happening now.
So I think basically we start off with a base software, and then as you rightly said, there are two challenges. One is affordability. In Western countries, there are two things. Usually there is an insurance that actually pays for this. Also, either insurance or there are standardized care pathways which the government or the insurance acknowledges and say this is the way that you have to take, and then the insurance actually pays. In our country, in my opinion, both are not there. There is no standardized care pathways, nor most of the patients are actually paying out of the pocket. So again, we need to take customized care pathways that are good for the patient, that's good for the local ecosystem also. And this creates a lot of challenges when it comes to software. Software requires a standardized workflow, otherwise it becomes extremely complicated. How many such instances do they happen? Is it like every step needs to be redesigned, or in your experience in being in medical informatics, how much customization have you suggested and how much has it been actually done to your satisfaction?
Now, when I say customization, from the clinical perspective, first of all, I have to be very clear. When I say I, my clinical team has to be very clear what they want. So you can't say X doctor does that way, Y doctor does this way. To some extent, there has to be a unified way of working to specialty. Let's say cardiology, there has to be a set methodology of working as far as the narration of the clinical history and everything is concerned. You can't be customizing to every doctor here. So same thing, what really happened was, one doctor said, I don't want this test, the other doctor said, I want this test. So I said, we can't do it. Else you all get together and have a discussion among yourself and send me a document, what do you want? One document, what do you want? Okay? That will be escalated to the vendor. See, again, the customization is, so the clinician thinks customization, when they give it, the computer does everything and it will come back to him in no time. No, it's not. There are a lot of other processes involved. We need to develop a CR that has to go to the software vendor, and he has to give me the finances for that, and a lot of things involved, money involved. As I said, the finance, the economics behind the development of all those things. So naturally, what happens is, one, I always tell my clinical unit, have one set of case sheet, whatever you want. And whatever you don't want, which we have been doing unnecessarily, if you don't want, tell us you don't want all this. So that's one way. Second thing is, my level as a fellow clinician, I go through the particular case sheet and I discuss back with them, do you want all this thing again? Right? Then we escalate to the vendor to do it. So vendor will always have, just a integration, there are just a frontline change. Sometimes he says I have to write coding, so based on this the timeline differs and the things takes a little longer time. But you at one point of the time, I have told my clinicians customization stops at this level. So anything whichever you want to ask me will not be under customization. It will be an addition to your existing product that's going to cost for us.
Yes.
That's what I used to say.
Yeah. I think although we assume that everything is possible in software, realistically certain modifications can happen quickly, but certain new feature additions I think need to be budgeted, and that's a completely different workline also. There's actually a lot of steps that need to be done. How do you kind of justify? I mean, I think every step that anybody wants as a customization or a new feature has to be justified also, right? So how do we actually justify these steps, and what kind of real benefits do, as you mentioned, patient, physician, the system, the hospital system itself, where are actually the benefits? Can you define maybe the top 3 benefits or even more if possible?
See, let's assume cardiology, or let's say my field is pulmonology. See, customization which really address or improve the care of the patient, that will be the bottom line. Number 2, which will cut down the expenses for the patient. As I said, I don't want to do unnecessary tests, though the machine says do this test. I don't want to do unnecessary tests. One is appropriate care for the patient, because ultimately now the healthcare boils around the patient, who is the end stakeholder. One is that. The second one is the cost. Cut down the cost. 2. 3 is comfort level for the clinical team while doing the work. When I say comfort level is, I don't want the doctors to get into burnt out situation. As simple as possible, customization if we do it. And when I say customization, one example I can quote, it's like copying the previous order is also a customization. So first time when there is an order being given, a list of medications, next time the doctor is going to give the same medication, why should he sit and type it? So what I request to them is, I want everything to be copied and the number of days has to be allowed to be changed, and it comes and sits in the current document of that particular day. So these are the things where to make the doctors at comfort, to address the patient, improve the care of the patient, to cut down the cost for the end stakeholder called the patient.
From a hospital perspective, so if we get all this information or the data around about patients, about how the service is actually being delivered, how the practice is being done, from the hospital level, what are all the benefits that the hospital can get?
Okay. So when I started implementing, I never thought from the administration perspective. I started from looking only from the patient perspective and the clinician perspective, because I am a clinician, I am a clinical champion. So I started looking only how, in what way it's going to help me as a clinician, in what way it's going to give me comfort. That was my first thing. Second thing, in what way it's going to improve the patient's time. Okay. And as I grew into the field, become a medical informatics officer, I have no choice. I have to look at from the administrative perspective, because administrative data is one of the pillar for the data. So now, when I look at from the hospital perspective, a lot of things we have changed is the turnaround time, patient waiting time has come down. Discharge process has improved. Duplication of medications between two consultants has improved. There is the error, especially the medication error has come down. The repetition of diagnostics. For suppose you have asked for hemoglobin, I have asked for a CBC, right? So naturally the system has an inbuilt alert saying that some Dr. Kuppuswamy has asked for an HB already, you want a CBC. All those alerts are inbuilt. So these are the advantage from the management perspective. Ultimately, we call it as NPS score, patient satisfaction score. We have one of the NPS as one of the metrics. We measure NPS from the patient perspective, and that is being considered from the administration as an important metric to say that we have improved in the process of care delivery to the patient.
I think that's fantastic actually. In fact, you have put them into really very crisp bullet points. Just to repeat, turnaround time and then the discharge process, which again is an extremely time consuming process. Even if some amount of time can be cut out and efforts can be cut out, then it will be very helpful for the patient and for the hospital also. And then duplication of medicines, and then reducing the errors, replicating diagnosis or repeating the diagnosis, which if it can be avoided, again a cost saving and again a time saving. And I think all combined into one indicator, which is the net patient satisfaction. I think that's actually fantastic.
NPS score.
Yes, NPS score. Sir, is your hospital a large single hospital, or are there actually multiple chains?
No, it's not a chain. It's just one hospital in one area.
Can you describe your setup? I mean, how many beds, how many specialties, number of patients, just approximate number.
Okay, we are a 750-bed hospital, and we have 40 specialty. See, in fact, GKN was started as Gynae, pediatric and oncology hospital initially. Now we have spread our wings into every specialty. We have under medicine we have 20 specialty, under pediatrics, even under pediatric we have 10 specialties. Under surgery we have robotics in our hospital. We have a robotic surgeon in our hospital. And we have spread our wings. See, that's the call of the day. We have no choice. When everybody around is growing, the economy also has to grow, and we have grown to an extent like this.
That's fantastic to hear, sir. Well, you have also come to our facility. I think Mallareddy Vishwavidyapith, where we have about 3 hospitals. Fourth one is coming up. There are 2 medical colleges. But we are also, or we have already set up India's first school of digital health, where we are offering bachelor's, master's, and PhD programs, a variety of them actually. Now we are at this so-called intersection, which is healthcare is there, technology is there, and then, as you rightly said several times, change management also needs to be built in. How do we teach our students, especially the young students? What do we teach them in digital health? Can you again, as you kind of make everything very crisp and in a very bullet point way, can you tell us top 3 things that we can teach our students?
See, number one, the change towards digital trend in healthcare. I think unless they understand why this change should happen, and the other learning process is not going to really help them out how to do it. They have to know why to do it, then only they will be able to learn how to do it. That's the first thing. Second thing is, as of now, I'm sure there are no excellent teachers to teach the students in this field. Okay, as I said, emergency medicine. When emergency medicine was brought in, we had teachers from various domains. We had teachers from anesthesia, we had teachers from general medicine. That's how it is. Same way, for example, I'm a pulmonologist now into digital informatics, right? So we all should pitch in and teach the students to bring them the first or second batch as the initial teachers, so that they'll take the flag forward in this field called health informatics.
As you are the clinical champion, I think we need to create champions out of students now.
Exactly.
How do we also kind of make the students go around and understand the challenges in healthcare? As you said, the reason why clinical champion was actually created was to kind of bring somebody from within the group so that they can actually convince. But when you are actually looking at new students walking into a hospital and then making them understand, how is that possible? Would just be an immersion of them, observing things should be okay, or can we actually do more?
Now, see, when they finish the course or during the course they come for a, let's say, sort of a training in a hospital setup to know what's happening. They should be part of the healthcare team. That's a way to learn. See, otherwise what really happens was, what really failed in us is, when the technology fellow went and told the doctors were not listening. When a fellow colleague like me, clinical champion, sitting and talking to them in the canteen when we are having a coffee and telling them, casually talking to them, so they have to be part of the team. Like, you have your interns, part of the team. Same way, you should put your intern, digital health informatics students as an intern, to be part of the healthcare team, so that they understand the nuances on the either side. Otherwise, what really I predict will happen is, there will be a technical person. We don't want them to be a technical, I want them to be a 360-degree holistic person who can understand the need and the supply on both. Need of the clinician and the supply on the technical side.
And in your opinion, any specific technologies that they should be knowing, or how do we kind of understand?
See, basically they need to know computer science.
That's true.
That's the bottom line. See, as a doctor, I just need to know how to type it. I just need to know how to do it and all those issues. That is the basic thing. Second thing is, they need to understand what is informatics from the technical perspective, completely end to end. See, for example, they need to understand the software, they need to understand the hardware, they need to understand the process, and they need to understand what we call, as I said, the holistic way of looking at it. They need to understand what is the real need of the end user, how do they design, how do we, as I was telling them, they need to know coding, they need to know what is integration. They need, it was very funny when they told me, initially, sir, it's a bug, sir. initial days, they used to tell me it's a bug. I said, what do you mean by bug? Finally, I didn't know what is the bug. I can simply take it as it's an error, so they're correcting it.
Yeah, poor coding is actually.
Okay. So, I didn't leave it until I said, one of you have to explain to me what is the bug. Because otherwise, what really happens is, if I don't understand what is the bug, I'm listening to their stories.
That's true.
Technical stories. Okay, technical jargon. So your student needs to understand the front end and back end both, technical and the clinical. How and they have to be the catalyst on either side. They can't be seeing things only from the industry perspective.
And I think, as you rightly said, we also need really good teachers, and we also need really good teaching material also. Can you kind of, in your experience, highlight certain good hospitals or good processes that are working reasonably well that can potentially be documented and also conveyed or taught to the students? In your experience, which hospital does really good things, or which setup actually does good things on a digital platform?
See, I again classify the in-house teams are always doing good. If they have an in-house team building their own software, I visited Narayana Hridayalaya in Bangalore.
They have a very big.
They have it's called Atma.
Yes.
They have an Atma team. They do it excellently. But the CA is there today in Hyderabad for the meeting which we came for. And see, what they said was, that's what I said, they are part of the team with the doctors. Even they don't go, the IT team doesn't go on separately and they're in a different room to eat lunch. They go there and sit with the doctor to have lunch. They have a discussion during lunch with the doctor. They go out for a tea with the doctor. That's how it goes. So Atma, to my knowledge, the plugins are always a troubleshooters. When you get a software from outside, you plug it into your system. When you escalate them, I told you, they say it's a bug and they need a CR. We need to give a BRD and they have to work cost for that. And all those issues come. The same thing also happened with the internal team. It's not that they're not doing it. But since there is enough good communication between the team, they understand each other and they get it done faster. So in-house team, any organization who develops an in-house software, to my knowledge, they are doing good.
Well, it's been fantastic talking to you, sir, and I think we have learnt a lot. But I think we need to start some kind of an ongoing collaboration so that, as you said, a lot of these things need to reach the students, but we need to be in continuous touch. And I think share some work on both the sides and hopefully continue to work together. Thank you for visiting our place, and it's fantastic talking to you.
Sure, sir. Thank you. I'm also, I'm also interested. As I said, whatever I learn, I have to give it to somebody to continue the legacy. And if I don't give it to somebody, the legacy is not going to be carried forward.
That's true.
So I'll be happy to share my experience and knowledge to all your students anytime. I'll be happy to visit your institutions as a need. I can definitely help your students from a practical perspective, not from a theoretical perspective.
Absolutely, and that's actually what is required. So thanks a lot, sir. Thanks a lot for the offer. We'll definitely follow up and then make sure our students get the best knowledge.
Thank you, sir.